Thank you so much for coming out this morning. Big crowd, I love it. I love it. And some familiar faces too, I haven't seen for years. So thank you. My name is Robert Underwood. I'm a neuropsychologist at Fraser Rehab. If you don't know what a neuropsychologist is, don't worry, nobody does. Not even the doctors I work with. But a neuropsychologist is a specially trained psychologist, all right, in clinical psychology. But we're also trained in functional neuroanatomy, meaning the brain and how it works, neurology, pharmacology, imaging, all those different things the brain does. So we're kind of an overlap, cross-disciplinary type of clinician or psychologist. So we're not your typical shrink you go to and talk about your problems, right? I'm not very good at that. I have enough of my own problems, right? So we kind of refer out for those kinds of things. But I'm a clinician on different disciplinary teams within the University of Louisville School of Medicine. We're on the DBS team, epilepsy team. We do a lot of cognitive testing of patients who have issue with memory, problem solving, confusion, delirium, thinking, tumors, strokes, head injuries, cancer, Parkinson's disease, encephalitis, all different types of diseases and conditions that affect the brain. We will end up seeing them perhaps to help the doctors figure out what's going on. So that's a little bit about who I am professionally. Personally, I have a connection with Parkinson's disease. Many of you know my dad had Parkinson's disease many years ago. He's no longer with us, but it got me started in the Parkinson Support Center of Kentuckiana many years ago with Jay. And so I was on that board of directors for quite a while, and was so grateful to Erica and Eric when they kind of stepped in and kind of put this institute together to fill that gap at a grassroots level for you guys, right? It's so important to have each other. I saw so many people, greeting out there, talking, smiling, hugging. It's a close group here in Louisville of people, and Eric and Erica realized that, and I'm forever grateful for you guys. You've done a great job for the community. We appreciate you.
It's hopefully.
So we're going to talk exciting. This morning, my last talk was about depression and anxiety, but it was too depressing. So Erica said, don't do that again. Talk about something else. So we're going to talk about cognition, and we're going to talk about dementia and cognitive changes in Parkinson's disease and in other movement disorders, okay? As always, if many of you know me, I have an ambitious deck of slides here, all right? So we're probably not going to get to them all. I usually will talk fast and quickly, but I'll try and slow down and take any questions as we go, okay, if you have any, all right? So we're going to start off by meeting Elizabeth, okay? So Elizabeth is kind of a common patient that I might see in my clinic. 62-year-old female. She's had Parkinson's disease for about 7 years, and there's her medical history. Not uncommon to have a lot of other conditions, right, as you get a little bit older. High blood pressure, diabetes, migraines, in her case, sleep apnea. These are the medications she's on. We'll talk about those in a little bit. And here we have also her complaints. All right, she comes in, sits down on my couch and says, Doc, I have trouble remembering stuff. Can't think of words, seems like I can't keep up with conversations when I go out. If I go out, because I'm depressed. I don't want to leave the house. I don't want to do too much. Don't want to be around my friends. She's also kind of seeing things in kind of the side of her vision, and they're not real to other people. When she says, hey, did you see that? Did you see that? No, didn't see that, sorry. And so she's still, taking care of all of her needs at home. She's still taking her medicine like she should. She's still able to make her appointments, pay her bills, things of that nature. Okay? So that's Elizabeth. All right, maybe that sounds familiar? Yeah. All right. So what's going on? What do we think's going on with Elizabeth? Are those just normal symptoms for her age? Could be. All right. We'll talk about some of the normal changes in thinking. Could be. Or maybe she's experiencing some legitimate neurocognitive changes, okay? Due to, don't know. That's why she'll come and see me. If she does have some legitimate changes, what's the cause of it, right? We're gonna find out there are lots of different types of causes for dementia and for cognitive changes. Or maybe she's just depressed. The most common reason I get a referral is, doc, is this just depression or is there really some dementia or cognitive change going on? Is this really anxiety? Is this really PTSD? Is this really just a cognitive or just a psychological condition? Or is there really legitimate change going on? Or maybe it's even something else beyond that. Okay? So those are the questions I'm faced with many times to figure out. Okay? So, nothing is ever contained in a single box as we progress along that continuum of cognitive change. Everything is a continuum, right? So you have a little bit of normal, a little bit of clinical change, and a little bit of dementia, all right? So the progression looks like this, from normal age-related changes, and we'll see those in a second, to a clinical term called mild cognitive impairment. All right, so that's not only a clinical term, but a descriptor of what's going on. All right, you have mild changes in your thinking that are not normal. And then the next stage, if MCI progresses, it turns into dementia when a threshold is crossed. Okay, that threshold being, are you still independent in your functioning? Okay, we'll talk more about that. And there will be a test at the end, because we're going to be measuring your memory. Alright, so just FYI, I like my tests. So this is the continuum. Alright, so what does normal change look like as you get old? Alright, things just slow down. Alright, things just get slower, that's natural. The most common complaint I get every single day, I have trouble finding words. I can't think of the word I want to say. All right, it's on the tip of my tongue, right? More often than not, that's totally normal. So don't freak out, don't worry if you're experiencing that. I've already experienced that today. Normal. We're less efficient in how our brain learns information and gets it into our memory. And you'll see here in a little bit that with Parkinson's disease and other subcortical types of dementia, memory loss is not really a central part of their clinical condition. So it's not a loss in thinking, or not a loss in memory retention and the ability to hold on to what you've learned. It's a difficulty getting it in to begin with, right? But if you can get that stuff into your memory, you're usually gonna hold on to it, or it's gonna be there somewhere. You might just be inefficient in how you're trying to get it and have trouble finding it, okay? But it's not a forgetting type of disorder like Alzheimer's disease or Alzheimer's dementia. So your memory is just less efficient. Kind of like an older computer, right? Just kind of slower to run. Not as much RAM, if you will. Some things might even get better when you get older.
What?
That comes at the end. Your crystallized knowledge, meaning your facts that you learn, increase as you get older, right? The more you read, the more you experience life. And believe it or not, some degree of fluid reasoning gets better. They've done these tests where they give young people problems to solve, and then they give older people problems to solve. And the older people kind of do better than some of the younger people because they have more experience to base it on. They come up with a solution that's a little more creative in some ways than the younger people, believe it or not. So yeah. So here is that continuum I was talking about before. So we have normal aging in green, right? So that's everybody's going to experience some changes in their thinking. And it declines a little bit. But then we have these other clinical and preclinical stages where there are some silent changes that aren't really detectable by my tests. And that's that preclinical stage over there. And what I see here are really bright people coming in sometimes and saying, Doc, I know something's wrong. I do testing with them, right? And I say, sorry, no, all your tests are fine, okay? But I see this a lot in bright people who really are able to detect that subtle change in their thinking that our tests aren't sensitive enough to pick up on yet, okay? But they know something's going on. And then you move into this next stage called mild cognitive impairment. So this again is a clinical term, it's also a descriptor of changes in your thinking that are not normal for your age, okay? And number two, they're mild enough that you're still able to function normally at home. And that's that threshold I was talking about before. Your functioning is not impaired. And by functioning, I mean things like, can you still make your own appointments? Can you still pay your own bills? Can you still take your own medications, without forgetting, losing them? Or does someone need to help you with those instrumental activities of daily living? Okay. So when you come see me, I'll ask you a lot about what's your system for taking your medications? How often do you forget them? Does your wife help you? Who orders them for you? What are you taking? Okay, to see if you can understand and if your system is effective in being able to keep track of your daily responsibilities when it comes to medications, appointments, and bills, and taxes, and business affairs, and driving. Okay, how often do you get lost? You have to use a GPS, things of that nature. So that's the threshold that moves us from MCI to dementia. Okay, if at some point along that continuum and that threshold crosses just a little bit into, I need more help. My wife's having to call for my appointments, get my medications. I forgot, the bills last month. Last 3 months, honestly, and our lights got shut off. Okay, then you're in that stage of dementia. Okay, where the cognitive changes are impaired and severe enough to interfere with your activities of daily living. And then within this, right, you also have different degrees of severity, mild, moderate. Sometimes it's hard for us to distinguish between MCI and dementia because maybe your wife has always done the bills and taxes. Yeah, I don't do that. Maybe there's not an informant that comes with them to the appointment. So I don't have anyone else to talk to, and they just say, oh yeah, I'm fine, I'm still driving. Yeah, no problems. I talked to his wife later and said, oh no. He was supposed to go to the outlet mall, but he ended up in Indiana somewhere. Don't know how, he was just there, he got lost. So sometimes it's hard for us to distinguish between the MCI threshold and the dementia threshold. So these are just a couple other parts of the diagnostic criteria that we look at. There must be someone in your life or yourself that says there's a change, right, in my thinking. And you still can be working, you still can hold a job, you can still go out and function daily, without too many problems for a diagnosis of mild cognitive impairment. Again, with dementia, these are going to be significant cognitive changes like MCI, but here you're not able to do it independently, function independently any longer. And you can't keep your job, you get let go, you're unable to socialize effectively. You might sit in the corner and not talk much, you're too overwhelmed with the conversation and being able to kind of make sense of what's happening. So your social functioning and work functioning is affected. So when I say cognitive changes, we're really talking about a number of different domains or abilities. Okay, and these are the types of abilities that we all measure in the lab at U of L when you come see me. Jay, you intimately know what a neuropsych eval looks like now, right?
Yeah.
So they test all of this. We test attention, we test language, visual spatial skills, memory, executive functioning, motivation, self-control, mood, personality, depression, anxiety. We test all of those. So these are the areas we're talking about in terms of change that we look at to determine, is there a significant decline? And usually by significant decline, I mean 1 standard deviation below the mean. So that means basically think about a normal distribution curve. IQ is 100 for most people, right? So if your scores on some of these tests are an 85 or lower, that's significant, okay? So we kind of use some psychometrics and some data and some numbers to determine, is that change on these tests of attention, language, memory, and so on, big enough right? To consider it significant, all right? So these are the different areas. We'll talk more about the central areas of Parkinson's disease and essential tremor that are affected in particular, okay? And this is just a fancy slide that talks about how MCI is further classified. Peterson is kind of the original author that put together the mild cognitive impairment syndrome and classification system, and he divides it into two types of MCI. Amnestic, meaning your memory is mainly affected, and non-amnestic, meaning your memory is not mainly affected. You have other domains that are mainly affected. And then he talks about, okay, if your memory is mainly affected, is it just memory, or are there other domains like executive functioning, spatial functioning, attention, personality that are affected? And if so, then your type of underlying disease might be Alzheimer's disease or vascular dementia. If it's just memory and nothing else is affected, you're probably at a greater risk of Alzheimer's disease. Over here, if your memory is not affected and it's just executive skills or spatial skills or attention, and just one of those, you might have one of these types of dementias. Similarly, if your memory's not affected, you can still have other domains that are affected across spatial, language, attention, and that would also put you at greater risk for other types of dementia, which we'll talk about here in a second. Any questions so far?
The letters down at the bottom. Frontal temporal.
Exactly. Okay, so on your test, you don't have to take the test. You already get an A.
But I don't know the other ones.
That's awesome. Dementia with Lewy bodies. Parkinson's disease dementia. Alzheimer's disease and vascular dementia. So you've already kind of got the preview. I answer this question all the time, right? Alzheimer's disease is not the only type of dementia, right? It's very confusing to people. So I kind of draw out an umbrella, all right? And I decided not to draw because, you don't want to see my drawing. Trust me, you really don't. So I found this picture. This is from the Utah Department of Health and Human Services. So dementia, remember, is just a clinical term, right? It's kind of like virus, right, or a shoe, right? There are lots of different types, right? So dementia is just this clinical term, and you know now how it's defined, right? But there can be many different causes for why these changes are taking place in your brain, right? One of them, the most common one, might be Alzheimer's disease, right? But then there can be lots of other types of dementia. There can be Parkinson's dementia, HIV dementia, there can be vascular dementia. You can have dementia from traumatic brain injury, from Huntington's disease. You can have frontotemporal dementia. You can have Korsakoff syndrome from alcohol abuse. That can cause dementia. You can have normal pressure hydrocephalus, posterior cortical atrophy, atypical frontal type of Alzheimer's disease. I can go on and on. Lots of different types of diseases or underlying causes that create these changes in our brain. Most common being Alzheimer's disease, and then vascular disease, and then Lewy body dementia, and then frontotemporal dementia, and then these others. You can have a tumor in your brain that can cause dementia. Parkinson's, and then even within Parkinson's syndrome, we have these Parkinson's plus types of syndromes like cortical basal degeneration.
How's the ET has the question mark? Is that
Yeah.
because he forgets to phone home, or what is that one exactly?
Nice, yes, exactly.
Now what is that one?
The literature is kind
The essential
of
tremor?
equivocal about that.
They don't know yet.
There are definitely neuro pathways that change in essential tremor, and they're starting to believe that it can by itself be a cause of dementia.
Okay.
At a 2 times greater risk of getting dementia, mild cognitive impairment in MCI, or in essential tremor. Yeah, but research is a little bit more equivocal about that.
Can dementia be reversed?
Yes, it can. You get an A as well. You're off the test list.
Hello, Alzheimer's.
No. No. Although we are at an interesting time in Alzheimer's disease treatment. Have any of you heard about the new medication for Alzheimer's disease? Anti-amyloid. Where for the first time we're actually going in and they're getting rid of those amyloid plaques through this medication now. Yeah. Yeah, it comes with some risk of brain bleeds, right, brain swelling, and it's only for people who have MCI or mild dementia. And now you know what that means, right? Because that's what the study was based on. Only people with MCI on that continuum or mild dementia can get it. Okay, but yeah, it's a kind of interesting time where we don't know yet what the reversibility of that's going to look like long term. But before, we just had these medications. Have you heard of Aricept? Excellent. You know, I mean, they slow it down a little. I'm not a physician, so I'm not going to be as, you know, like, take this medicine, it's going to help a lot. It's just kind of this slowing, very subtle slowing down process that can help with keeping you out of the nursing home a little bit longer and maintaining your functioning a little bit longer. Okay. So that those types of medicines we have now are really more beneficial for kind of maintaining your quality of life a little bit longer. Okay. But that's a great question, and it leads right into the other slide here. When you come to my office like Elizabeth, we want to make sure there's not something we can treat first, okay? There are tons of other reasons why you can have memory problems and cognitive changes, especially if I see a 40 or 50-year-old in my office and they're saying, I can't remember anything. I'm not thinking dementia. I'm thinking base rate is high for what? Depression, anxiety, reversible causes, okay? So all of these things you can treat and you can reverse the dementia. We kind of say about 10% of dementia are reversible. Honestly, that kind of comes down to more like 2 or 3%. But yeah, some of them are. Medications are a biggie. Some medications we don't want you to be on, it's gonna affect your memory. B12 is low, B1 is low, thiamine is low. You have hypothyroidism, it's not being treated. You have hyponatremia, other types of renal or metabolic dysfunctions. All those can cause cognitive changes and cognitive impairment. Have they been, have your labs been checked? Important part of the workup you'll see at the end for Elizabeth. Alcohol use, it's a big one, right? Talked to somebody the other day who was drinking 100 drinks per week. What's that?
That's all.
Right, I mean, come on, get with the program. In college, I was up to 150. So obviously they're gonna have some cognitive effects from that, right? It's a central nervous system depressant. Depression, as we talked about, you can have what's called old school. I'm kind of old, I've been doing this 22 years. Old term is pseudo-dementia, all right? Pseudo-dementia, like a fake dementia because you're just too depressed, right? And it can look like dementia. All right, yeah, it can look like dementia. I remember a lady I had, she was in her 60s, so the base rate was, it's up there. I might still think about dementia, but she had a meshed relationship with her mother, like dysfunctional relationship with her mother. They got into an argument. Mother said, I never want to talk to you again. Hung up on her. This lady went off the deep end. Her husband quit his job to take care of her. Okay, mother's gone now. He quit his job. So she comes in and she's kind of vegetative, right? She's just not saying much. She's just, I don't know. Well, she got diagnosed with dementia, right? But was it dementia? No, it was depression from this attachment rupture, right, with her mother and so on. And now this kind of dysfunctional relationship with her husband, who she was getting secondary gain from as a caregiver. So, depression in that case. So some of those things can be reversed. Sleep apnea is a huge one, right? Your brain needs oxygen, just like your car needs gas. how many times have I said that in my clinic, right? A lot. If you're not treating your sleep apnea, you're gonna get dementia probably if it's in the severely classified type of sleep apnea. Right? You're gonna have microvascular changes, lesions from your brain not getting the oxygen it needs, right? You've gotta treat your sleep apnea, right? Otherwise you will get vascular dementia. But if it's mild or even moderate, you can treat that and your cognitive changes should get better. Tumor, NPH, you can shunt the NPH, and usually you get better. So dementia key points.
Could I ask a question?
Yes, ma'am.
Has there been much research about chemo brain, especially severe and longer lasting chemo brain?
Yeah, there's been tons of research on it. And it's a thing. Again, it kind of depends on how the chemotherapy is administered. If it's administered intrathecally through the spinal cord, that's the central nervous system, right? Greater chance of having cognitive changes. In some cases, you can have lesions on the brain from chemotherapy. We just had a case of a young lady who had ALL when she was young, and she had chemotherapy, had lesions on her brain, developed epilepsy. So we cut out part of her brain, where the epilepsy was starting. It just kind of depends on the case. Again, there are so many factors in the context of cancer, right, with depression and anxiety, and that might exacerbate some of those cognitive problems where it looks like they're demented or they're losing their thinking, but it's really just the psychological effect of how the disease and the fatigue is taking place. So, but yeah, it's definitely legitimate, but case by case. In some cases too, you can have delayed onset of that. You can have white matter ischemia and changes in your brain that come on several years afterwards. So it's certainly something to talk to your neurologist about if you're concerned. So many different points here. I think I've covered all those. The acquired means that you're not born with it, you get it. Okay? You can have dementia if you're 16 years old. How might that happen? What? Tumor, TBI, traumatic brain injury, car accident, brain bleed, stroke, right? And each one of those different types on the umbrella, they might progress at a different rate. And they all look different and manifest differently. In my office and at home, some types of dementia just affect speech, right? Who is it? Bruce Willis? Anybody know Bruce Willis? He has a type of dementia called FTD, frontotemporal dementia, right? Primary progressive aphasia. Some types of FTDs just affect personality. They come in my office and they say, and the wife says, my husband is not the same person he used to be, not at all. I mean, we'll be out in public and he will say the most inappropriate things to people. I mean, we'll be standing in line at Walmart and he'll start cussing out the 10-year-old kid in front of him. And I don't know what's going on. That can be a type of frontotemporal dementia. It's called impulsive personality variant of FTD instead of language variant of FTD. And then you can also have an apathetic type of FTD where that looks like someone who is extremely withdrawn, isolated, unable to motivate themselves, very, very apathetic, anhedonic, not interested in anything. And the patient that comes to mind in that case is many, many years ago where I tested a rock star. She was like a local rock star. She in a band and she was up on stage, and loved it. It was popular, well received, and all, over the years, then she just got extremely afraid of being in public around other people. She was withdrawn, couldn't get out of bed, and she had on brain imaging shrinking of the frontal lobe, and her clinical symptoms were consistent with an apathetic variant of frontotemporal dementia. So those FTDs, they happen younger and they go downhill quicker. Alzheimer's disease happens older and goes slower. Parkinson's disease dementia can happen anytime, but also goes even slower. Okay, so each type of dementia, again, depending on underlying cause, can have a different rate of onset, progression, and even duration. Okay. So in Parkinson's disease specifically, I'm not gonna have enough time. The prevalence rate for MCI is high. This is the highest number I chose. It's the lowest number is 27%. The highest number for MCI Parkinson's is about 40% that I could find. The most common type is not the type that affects your memory, as we talked about, right? That's Alzheimer's MCI. Parkinson's MCI is not centrally going to affect your memory as much directly. It's going to affect a different part of your brain, mostly those involving executive skills, which we'll talk about in a minute. And if you have more visual spatial problems, remember those different domains we talked about? And by visual spatial, I mean if you have trouble with directions, right-left orientation, putting blocks together, discriminating like distance, then that doesn't have as good of a prognosis as if you just have executive difficulties. So if you have non-amnestic MCI, there's probably a greater chance of getting Parkinson's dementia if you have more of those visual spatial deficits. Okay, and there's the prevalence rates for dementia and Parkinson's disease, 15 to 40%. The longer you have the disease, the more likely it is that you will get it. Sometimes up to 86% of people after 20 years with Parkinson's disease will get dementia. Okay. These are your risk factors for getting it. RSBD is REM sleep behavior disorder. Yeah, one of the earliest signs of Parkinson's disease. My dad used to do it. Oh my gosh, I'd go visit him and he would scream out, yell, wake us all up, flail. You know, sometimes people punch their partners, hurt themselves. So REM sleep behavior disorder. Other autonomic symptoms, things like orthostatic hypotension. You heard about that?
Yes.
Where you get dizzy when you stand up, low blood pressure. That can be a risk factor. The non-tremor dominant type, you know, probably from other speakers, are different types of Parkinson's disease. You know, the most common one is shaking, right? But you can also have, like my dad, the gait, you know, and the postural type of Parkinson's disease. And that has a much higher rate of turning into dementia than tremor. Sometimes, usually you just have simple or if you just have like tremor alone, and not a lot of these other risk factors, your chances of getting dementia decrease significantly.
What did you say RSBD is?
REM sleep behavior disorder. In essential tremor, what we see are similar types of executive deficits, just milder in nature. Okay. So we see, if we kind of use that same one standard deviation type of rule I talked about for significance determination. Let's say in Parkinson's disease, you know, your score might go from 100 down to 85, you know, maybe 80. In essential tremor, we would be looking probably more like 85 to 92, something like that. So there's a smaller impact. And you'll see where this impact takes place in the brain later on. But it's usually a milder type of profile in terms of symptoms. Again, executive are going to be most affected, as well as verbal fluency. So how quickly we can come up with words, our speech articulation, our speech production, how fast we can think of the words and say the words that we want. Our test in the lab is, it goes like this. Tell me as many animals you can think of as fast as you can. Go, Bob.
No.
I was just waking you up. Or tell me as many words you can think of that start with the letter F. Go. A. S, right? So those are verbal fluency, how fast you can access that information in your mind. That's the most common. And actually essential tremor does have non-motor symptoms as well. So some personality change, some depression, some apathy, some anxiety as part of the disease itself, just like we know exists in Parkinson's. We do see those non-motor symptoms occurring as well, to a lesser degree. Okay? And then the last point there is what Eric asked about earlier, with the question marks, that there have been some studies that have shown higher rates of dementia in essential tremor samples versus controls, but it's still a little bit equivocal. So what do cognitive symptoms in Parkinson's and essential tremor look like? Well, you know, they kind of vary from one person to the next, right? They're kind of all over the place, but generally we see these three things. We see slow processing, right, called bradyphrenia. We see trouble finding words, called verbal fluency. And then we see, first and foremost, executive dysfunction. Another way to think about executive dysfunction is the CEO of our brain, right? We all have one right up here in prefrontal dorsolateral cortex, okay? But basically, in Parkinson's and essential tremor, everything is smaller and I was really proud of myself making this. I brought my daughter in to see it, and she, being 18, was like, yeah, whatever. So executive dysfunction, this, as I said, is the core thing we see affected in Parkinson's and essential tremor, right? These are executive skills. Think about a CEO of a company. Maybe one of you or some of you have been CEOs of a company. What does a CEO of a company have to do? They have to organize, plan, they have to hire people based on efficiency. They have to determine goals. They have to be able to, multitask, right, to run the company efficiently. Make sense? So we all have an executive CEO of our brain to help us think and act and behave in a goal-directed, purposeful way. Think about this morning. You all said, oh, I have to go see Dr. Underwood at 11. Oh, I don't want to do that. But I have to get up at such and such time. And I have to plan for traffic. And I have, so you're kind of thinking ahead, right? Think about packing for a trip. Okay, where am I going? Ireland? Okay. All right, what's the weather like in Ireland? It's cold, right? So I need to pack this, this, and this, right? That, by the way, is kind of my litmus test for measuring executive skills. Is if someone tells me they went on a recent vacation, I ask them about how the packing went. But the working memory is how well we can just temporarily hold stuff in our brain just long enough to do it. So we don't want to hold on to that memory forever. If I just say, Bob, go to the kitchen and grab me 2 cups of sugar and some salt, right? What was I thinking? That's working memory, like multitasking, keeping kind of things just in our active memory so that we can carry out a task, okay? And I highlight these because these are big time affected in Parkinson's disease. Self-monitoring, this is kind of like we think about our behavior, we're thinking about what we're doing now. I'm thinking to myself, I'm running out of time, I'm never gonna have enough time, hurry up, so that's my self-monitoring. Thinking about our thinking, we also call it metacognition. Okay? So those are executive skills.
What was the response inhibition?
That's impulse control. So people with Parkinson's can become more impulsive in their behavior and their comments. They have trouble blocking out distraction or competing information. So they might have trouble attending in a group because they just can't inhibit everything going on around them. Oh, squirrel. Right? So that's kind of response inhibition.
So you're just talking about me, ADHD.
I didn't want to put Eric up there, but that's who I had in mind for that. So this is what it kind of looks like. So you're going to be slow, right? But you can get there, usually in Parkinson's and MCI, maybe less so in dementia. You'll eventually get there, it just takes longer. Likewise, the words in there, your verbal fluency, it's just going to take a little bit longer to pull that specific word out. Might be distracted. Large groups are going to be hard for you to pay attention in. Not focused as well, perhaps. With the working memory piece of it, you might get distracted while you're trying to do something and have to go back and start all over because you forgot the steps of what you were supposed to do. Your problem solving, I see this a lot. You might get stuck. Might do the same thing over and over. You might not learn learn from your mistakes. Might not take in feedback very well. We have a test here where we actually ask people to solve problems. Maybe some of you have done it by matching cards, and then we give you some feedback. Oh, you're wrong. Try the next one. That's wrong too. Try the next one. Oh, that's wrong too. So this person isn't taking the feedback and thinking about conceptually what could make their answer, their choice right. Okay? So they tend to get stuck or rigid. I call that mental inflexibility. They don't have the mental gymnastics to be able to kind of think maybe bigger or broader. Impulsive. Again, making more errors, but they may not realize it, and they may not self-correct. Okay? And just kind of inefficient. Remember we talked about memory, so how you get there might not be the most direct route. You might be more inefficient, disorganized in your approach. So that's kind of what it looks like day to day when we're talking about probably more MCI, but also mild dementia in a subcortical type of disease like essential tremor or Parkinson's disease. Okay? Other cognitive changes, language is spared. Big difference from Alzheimer's disease. If I give you tests and your language scores are low, yeah, that's concerning for Alzheimer's disease. Visual spatial abilities are not too bad. We see that a lot worse in Lewy body disease. That's a distinguishing feature for me in the lab. If someone really struggles with that and has Parkinsonism, probably Lewy body disease. Again, memory, storage, this part here is not as effective as this part here in Parkinson's disease and essential tremor. So these are the frontal executive skills that are important for memory to take place. Okay, we have to know what it is we're trying to remember. We have to selectively attend to Eric nodding his head right now and not her holding up her phone. Selective attention, right? And then we have to block out all the other distractions. I guess that was more so my example, right? And focus just on what we want to remember, and then we have to organize it. And my example here is, if you just close your eyes and take a file and open your drawer and drop that piece of paper in randomly, and then you close it, how easy is that going to be to find it? It's going to be kind of hard, right? But if we, organize it in our brain file neatly, in an associative way, something meaningful, connected, logical, in the same group, okay, then it's going to be easier to remember, right? So in Parkinson's disease and essential tremor, that's the key to memory, is organization. If you organize it and it makes it in, it's probably going to stick. Not true with Alzheimer's disease, okay? It's not going to stick, no matter how much you organize it or repeat it. Okay, so practice can help, right? Reminding can help, cues can help, all those things can help. And if cues and reminding don't help, try a sticker. Try a sticker. We see some psychiatric changes in Parkinson's disease as well. If you go to my other talk, you would know more about these. But we do see these psychiatric changes, like I talked about, in personality and mood, in Parkinson's dementia in particular. Hallucinations are very common in just Parkinson's itself, right? Even if you're not demented or have MCI. I want to say about 25 to 30%. Usually more visual, more auditory. They're usually well-formed people, animals. Sometimes their passage, like something in the corner of their eye. Sometimes their presence, hallucinations, like there's someone in the room with me. I just feel it. Right?
That can also be medicine-induced too.
Absolutely. Dopamine agonists. Delusions, we can see a lot of delusions, paranoia, imposter, replacement, like my husband is not really my husband is someone else. It's called duplicative paramnesia, or my house is not my house, this is a replica of my house. Things like that. Depression, anxiety, apathy are common, those are my other talk. Lewy body disease, I'm sure, especially this lovely lady in the front who knows what FTD is, knows disease. I just threw it in here, it's a whole different talk, whole different disease, but it does have a huge overlap with Parkinson's disease, because you do have tremor usually, or I'm sorry, subtle tremor, very subtle tremor usually, but you have a lot of cognitive and psychiatric changes. That's really gonna be what we see manifest mostly in Lewy body disease, where you're coming in with hallucinations and paranoia and cognitive changes. Your tremor hasn't even started yet. The rule of thumb is kind of a year beforehand. You have to have these psychiatric changes start a year before your movement changes or your gait changes. All right. So yeah, and then you have what are called fluctuations in alertness, where you're just kind of zoned out. You know, you're just out of it for hours. There's a lot of daytime sleepiness, a lot of trouble with alertness, and it kind of varies within the day, within the week. So it runs the behavior disorder again too. That's very early on in Lewy body disease. And it has a lot of Alzheimer's pathology on testing. So you'll have more memory problems, more legitimate storage problems with Lewy body disease. Because we're running out of time. I know we started a little late, so I think I have a little bit of leeway here. But I'll just kind of rush through. These are why the changes are taking place in the brain. So this is kind of a depiction here of, you might have heard me say subcortical, right? This is cortical. Up here, this is subcortical, so that's kind of underneath that cerebrum of your brain, right? So this is kind of the basal ganglia, all this here. So where Parkinson's disease is affected. The substantia nigra is where the dopamine is produced, okay? And that's where everything kind of starts or falls apart, if we will. But we have the neurotransmitter called dopamine basically is depleted or not being produced enough by the substantia nigra. And because of that, you have changes in your movement, right? And you also have changes in other things, right? For those that have been to my other talks, you have changes in your emotions, and your motivation, and your mood, and your cognition. Because we know Parkinson's disease and essential tremor are not just movement disorders, they're neuropsychiatric disorders. Why is that? Because we have these, I'm gonna kind of toggle back and forth here. We have these three dopamine circuits, right, coming from the substantia nigra, right? STN, that's where sometimes your DBS goes. You're gonna have DBS, probably have it stuck down there, right? So you have these three pathways here, starting in the substantia nigra, and you have one that goes to your motor center, you have one that goes to your emotional center, and you have one that goes to your thinking center. Okay, so the blue one here this is the mesocortical pathway, so it goes to the prefrontal cortex, right? You heard me talk about that, right? That's your executive center, the dorsolateral prefrontal cortex. So eventually, as Parkinson's makes its way through the brain, again, the longer you have it, this network is going to be affected, okay, the mesocortical pathway. And then you have the mesolimbic pathway, which is that red? Green, right? Nucleus accumbens, right? That's your pleasure center, right? That's kind of that reward center, if you will. Feel good, center. So that's your limbic. Limbic is emotional or mood. So that's a pathway. And then you have the the red one, which goes to your striatum. That's your movement pathway. Your motor pathway.
Could you put up the slide just before this?
Yeah, I like that one. I couldn't decide which one I wanted to put up, but this one kind of depicts it nicely too. It just breaks down kind of the thalamic networks a little bit better. So we also put DBS here in GPI. It just depends. Someone asked me, why do a neuropsych? Well, because if you have a lot of cognitive problems or psychiatric symptoms, we're not going to put your lead here. We're going to put your lead here. Okay? Because if we put your lead here, all those things can get worse. Okay? So that neuropsych helps determine placement of the lead. Okay? So that just kind of breaks down the thalamic. And then in essential tremor, we do VIM. It's not on there, but VIM is the thalamus, part of the thalamus where the lead goes. whoops, so you can see kind of cortically and subcortically where those circuits lead to, right? The limbic being the emotions, that's why you have changes in mood and depression, anxiety. The associative being kind of your thinking and the executive dysfunction, that prefrontal cortex, this is the front part of your brain. Alright, so this is the frontal cortex, like the call right here. This is the prefrontal, this is where all the organization of things take place. These are the motor types of gyri. That's why you also have non-motor symptoms. This is the mechanism of cognitive change in essential tremor. Okay, so it looks a little bit different. We think the source is the cerebellum, right? Cerebellum's not nicely depicted there. It's nicely depicted here. This is a cerebellum. We call it kind of a mini brain. We used to think it's involved just in motor coordination. We now know it's kind of a mini brain and involved greatly in executive functioning. Okay, so that's depicted there nicely. If we go back here, you can see the pathway. Alright? Where the degeneration takes place. That's why we put the DBS lead in the VIM, right? And then the motor cortex. Motor cortex is where everything's planned, right, in terms of movement.
What's the inferior olive have to do with it? Going to everything? Down at the bottom?
That's part of the that's part of the pathway.
Okay.
Yeah, that's part of the pathway. It also controls movement.
So I have a question. It seems like that the Parkinson's starts with the substantia nigra and then spreads,
Yes.
it grows. Do they know what's going on?
It kind of, yeah, the protein kind of forms incorrectly. And you have these deposits of proteins, that synuclein proteins that are abnormal, and they just continue to be deposited
All right.
along the pathways, and then also the dopamine, just more widespread the dopamine loss, the more circuits are affected.
So if you could stop that, protein deposits, then you could halt progression of Parkinson's.
That's where all the targets of the treatment are.
It wouldn't get better, it would just stop it where it is.
That's where all the targets of the treatment are. For a long, long time, the targets of our treatment were how can we distribute carbidopa-levodopa better, consistently, smoother, right? And so that's been the main goal, but now we're using a lot of biomarkers and just like the anti-amyloid, we're looking at anti-synuclein.
Yeah, that's where that biomarker a year ago had come from, that misfolded protein.
Right.
They found in that
So we're
spinal
hoping to
fluid.
catch up with Alzheimer's disease.
You mentioned Parkinsonism, just briefly, can you
Yeah,
say?
that's a great question, very good question. You do not have dementia. Basically, Parkinsonism is an abnormal movement that kind of looks like abnormal movements you would have in Parkinson's disease, but it's not caused by dopamine depletion. It might be caused by, let's say, a stroke in the lower part of your brain, right? So think about the cause being not idiopathic depletion of dopamine, but some other reason why you're having these movements that are similar to Parkinson's disease, but they call them Parkinsonism, maybe because they're not sure if you have Parkinson's yet. Sometimes it takes Dr. Holliday, Dr. Hedera, a while to figure out if you do, but you do have, kind of these unusual movements. Well, you can have that from a stroke in these areas. You can have that from medications you've been on for a long time.
So Parkinson's doesn't necessarily lead to Alzheimer's or dementia.
It doesn't lead to Alzheimer's disease, but it can lead to dementia.
Through time?
The longer you have it, there's a greater chance you might get it. Depending on if you're a man, depending on if you have dominant tremors or maybe dominant gait problems and other risk factors like we talked about before. But Alzheimer's disease is a different type of disease. So Parkinson's won't necessarily lead directly to Alzheimer's Does that answer your question?
Yeah, thank you.
Yes.
Dr. Underwood, do you, is it just, we have better ways of diagnosing the different things, or is there an increase of neurological disorders?
Yeah.
Because every time you turn around, it's another person, you know, Lewy
Yeah.
body dementia, all
Yeah.
this. And it just seems like more and more and more.
I think it's both, and that's a wonderful, very astute question as well, and something we talk about, not just in Parkinson's disease, but in autism too, for example. You see those incident rates going up and up and up, so you're like, wait a minute, why are so many more kids? It used to be like 1 in 100, now it's like 1 in 50. You know, and I think it's a combination of our measures are more sensitive, our brain imaging become more sensitive, our biomarkers become more sensitive, and so we're just better at picking up on it. But maybe there are some environmental factors too, you know, like Vietnam War. You have that as a spike in Agent Orange exposure, where you're going to see spikes from environmental triggers. So I don't have the answer to that exactly, but I think you're on the right track, that it's probably a combination of things. So this is the, and I'm sorry we're almost out of time here, but this is the pathway of dysfunction, or the mechanism for dysfunction in dystonia. So dystonia is kind of this muscle contraction, you know, that doesn't go away, right?
It hurts too.
It hurts bad.
I had to stand up to clean my behavior.
Yeah, kind of like a Charlie horse, is that a fair way to
Yeah.
describe it? You want to get a Charlie horse before? Just have that all the time, right? That is dystonia, and so that pathway again comes from the cerebellum. You can see there on the left. Goes to the VIM again, and we have really good luck with DBS at U of L with treating dystonia as well. But then it goes up to the premotor cortex. That's SMA and motor cortex. So that's your pathway and where the dysfunction happens in dystonia.
If you can treat this with GBS, do you go in and put the lead still in the substantia nigra?
Not in substantia nigra, we put it in the GPI or STN for Parkinson's disease, or the VIM for central tremor and for dystonia.
Yeah, what if you have both? Can they do it? Have they done it?
We
You
can
do
definitely have
both?
both, and that's probably a better question for Dr. Niemann,
Yeah.
where they would decide the lead should go.
Yeah, because I've never asked if they've
Yeah,
done
that's a
a
good
2-lead type thing.
I know, I mean, you have multiple leads, you have 2 leads, or more. You have multi-directions, so they might, you know,
That's interesting.
change the directionality of that, but that's a good question for them. So when should you talk to your doctor? If you're concerned, of course. If your family members are concerned, remember we talked about that phase, that preclinical phase, where you think something's wrong, but, you know, nobody else is really noticing yet. Or maybe your wife is noticing it, or your husband's noticing it, and you're not, right? But if you've been married for 50 years, they probably know you pretty well, okay? My wife's always right. If things don't get better, if you quit drinking alcohol, if your B1 is fine, your B12 is fine, you run all the labs, your MRI is fine, and things aren't getting better. Or if your symptoms are affecting your mood, you don't wanna, get out, you're frustrated because you can't, do what you used to do. That's a good time to talk to your doctor, definitely. So what are they gonna do? They're gonna do lab work for those reversible causes. They're gonna do an MRI of your brain to see if you have a tumor or structural changes. They're gonna look at your medications. A lot of medications we don't want you to be on, okay? So they'll check for those, and maybe, sometimes a treatment is taking away medication. Yeah, sometimes that's a treatment by itself, is taking away medication. And then they might give you a screening. You've had the MOCA, right? Here are 3 words I want you to remember, or draw this clock. You've done that with your doctors, right? All right. Or they might send you to see me, and then you get the big shabam, right, for 3-4 hours. All right. And so we would test these things. We would do an in-depth interview. We would talk with your family. We would observe you. I'd start watching you as soon as you, get up from your chair, and watch you carefully when you walk. I always walk behind my patients, always. I'm I'm watching how they're interacting with their spouse and how they treat other people in the waiting room and my secretary. I'm gonna look at their brain scans, their MRIs, their CT scans, and then look at their blood work. I'm of course gonna give them tests, paper and pencil tests, computer tests of all those different domains we talked about ad nauseum. And these tests are important. What I tell my patients is, we're not comparing you to 18-year-olds, right? We're comparing you to people your same age, right? So you don't have to be perfect. You're gonna miss some things are gonna be confusing or maybe hard. Some are gonna be easy or silly. You know, they're all important because they all match a part of your brain, right? You just do the best you can, right? We'll give you as much help as you need, things like that, okay? But the important part of these tests is they're normed and they're standardized on people your same age, same education, sex, maybe even culture. Okay, so we have a very specific normative group. And all the tests are given the same way to every single person. Why? So we can generalize. You know, because that's how they were given to this part, or this group, so we have to give it to you this way so we can say, there's a problem, okay? And then we get concrete data points on your performance compared to other people in your same normative group. So, practical tips, things to do to slow down. Slow everything down coming at you. Don't allow plenty of time to process and get where you're supposed to be. Think about your thinking. Okay, remember, do those mental gymnastics. And what I'm doing, is that the best way to do this? Is there another way that's maybe better to go about it? What do these things have in common? I know I have to remember, and what's the best way to remember this stuff? So think about your thinking. Okay? Reminding and practice will help your memory. You know, so go over it a few times, smaller chunks, slower, but the more you go over it, the more you're reminded by it. That'll help. Try and do things in a quiet zone. Remember that response inhibition and working memory capacity is going to be limited, so you don't want the TV on, the radio on, a lot of people in the room when you're trying to do your taxes or focus on something important. You know, minimize those distractions. Think ahead, I already said that, plan first, do those mental gymnastics if you need to. So those are just some suggestions I tell people. These are some interventions and suggestions for the psychiatric and behavioral changes we talked about. I know my dad had hallucinations with Parkinson's. I've told this story before, you probably know. His hallucinations used to be a remote control cat that was flying around the room that had antennas on its back, and it was controlled by a little boy standing outside the window. You just watch it, you know, you just like chill, say, hey, how do you do? You know, don't try and challenge that. There's nobody there, what are you thinking? There's nobody there. You know, don't argue with them, it's just gonna make things worse, it's gonna make them feel bad. Reducing shadows, reducing stimuli that can cast unusual images, you know, in a dimly lit room. That sometimes can make people scared, paranoid, upset, induce some of their hallucinations. So we try and just make the room simple, make it clutter-free. Try and change the topic. You know, if they start to get stuck on something and they can't let it go, hey, what do you want to do tomorrow? Or kind of redirect them gently into something else. Provide them reassurance about safety. Everything's okay, hey, you know, don't worry. Structure helps a lot with dementia, doing things the same way, keeping things consistent. We oftentimes see when people move from one setting to the next, you know, they really kind of go downhill for a while. So keeping structure, I know it even helps for me to do the same things each day in the same order, in the same place where all my things go and all my steps of the day are kind of laid out for me so I know what to expect. So that helps a lot with dementia. So yeah, those are some suggestions there. Is it okay if I just run through a couple more slides here?
Oh yeah, you're fine. Okay.
So these are some medications that we do give if those other treatments don't work for MCI and dementia. The specific medication is approved for dementia with Parkinson's disease is called Exelon. That's the first one there. Of course, Donepezil is Aricept, which you can get also if you can't tolerate Exelon. Exelon is a patch you wear on your shoulder, your back. You can't tolerate that because these medications are sometimes not well tolerated. They'll give you Aricept, which is kind of the classic medication we've given to people for Alzheimer's disease, many years. And then if you move into that moderate or severe stage of Alzheimer's disease, they'll add on memantine or Namenda. So there's some research to support that helps a little bit. If you have hallucinations and they're troublesome, worrisome, scary, bothersome to you, they might give you Seroquel or quetiapine. They might also give you Nuplazid, which was a big groundbreaking medication for Parkinson's disease hallucinations, probably about 10 years ago. They ran through that pretty quickly to get it approved. I don't see a lot of people on it. I just don't. I don't think it's been as groundbreaking for hallucinations as I thought it was going to be, so I still see most people on quetiapine or Seroquel. And then a big one, like Eric said before, we want to get you off medications that are going to be causing you some cognitive problems or hallucinations. So many of you may be on dopamine agonists like Requip. They're going to increase your dopamine, right? So you might have more hallucinations from that. We know that if you're on things like benzodiazepines, if you're on Benadryl, if you're on Elavil, if you're on gastrointestinal meds for GI symptoms, all of those things can have anticholinergic properties that can affect your memory. The neuron that is involved in memory are the cholinergic neurons, right? So in Alzheimer's disease, we see the cholinergic neurons get depleted. So if you're taking medicines, what does anti mean? That are working against the cholinergic neurons, so you're kind of stopping your neurons that are supposed to be good for memory from working, right? And so things, like those medications like Benadryl, topiramate, Elavil, lots of other ones. We want you to get off those if possible.
What's the medications for the gastrointestinal problems?
Those would be like for incontinence, or like oxybutynin is a big one. Tizanidine is another one. So those would be things we don't want you to be on. And then of course treat depression, treat anxiety. That's a whole different talk. Treat your sleep apnea, any vitamin deficiencies that might come up. Definitely treat diabetes. Huge predictor of dementia. All form dementia. Diabetes is a huge predictor of getting dementia. Why is it important? Because of these factors here. Okay, so remember Elizabeth? All right, so she had 7 years. That's important, right? 7 years is all for Parkinson's. Tremor dominant type. Right, so what do we learn about that? She has all these other medical issues that affect her heart and possibly the blood flow in her brain. Right? She has sleep apnea. Is she treating that? Don't know. And she's on Xanax. That's a benzodiazepine. Not good. She's on Elavil, amitriptyline. Not good. That's probably the worst anticholinergic medication you can be on is Elavil. She's on carbidopa and Requip, right? Dopamine agonist. So you can already probably see the writing on the wall, right? So her neuropsych findings found 1 standard deviation below the mean in multiple domains of memory, executive skills, and spatial skills. Well, we know in Parkinson's disease we're going to have executive dysfunction, and we know it's going to be about 1 standard deviation below the mean, so yeah, it's possible. But she's got these other areas, right, that are affected too, like visual, spatial. Unless she has Lewy body disease, we shouldn't see that quite as much after 7 years of Parkinson's disease. And memory, you need to pull that apart, but her memory profile was not memory loss, right? Again, so probably not Alzheimer's disease, probably a subcortical type of dementia or disease. But she was moderately depressed on the psychological testing. So I gave her a diagnosis. This was an actual patient. I gave her a diagnosis of a mild cognitive impairment, multiple domain, provisional, meaning I'm not sure if this is really true, because there might be, as this gentleman said, some reversible things that we could fix first, right? Or if it's Parkinson's disease, MCI, or it's a mixed, that's something I didn't talk about, you can have a combination of all these diseases together. Or if it's a mixed vascular Parkinson's disease, disease, MCI. So sometimes we don't know right away. So sometimes we have to reevaluate you in 1 year to see what that progression looks like. Why? Because remember I said that every disease looks differently, progresses differently, acts differently over time. So when we have these data points from year 1, these data points from year 2 in neuropsych, we can literally compare your rate of change and literally plug in an algorithm to determine, are you really clinically worse, or is this just worse because you're familiar with the tests? It's called reliable change. She had no labs, she had no MRI done, she was on the wrong kind of medications, right? So there are some things in that 10% subset, right, that we could reverse still. No one was treating her depression, you know? So what we did with her is we had the workup, got her labs, found she was a little bit low in B12, so we had that, we replaced that. She was in the 300s. We started replacement of that. I talked to her physician about medications, and she was able to get off the topiramate or the amitriptyline because her migraines really weren't that bad at all. Remember, sometimes the treatment is taking away medication. I mean, I have not seen her back yet, so I don't know what she's going to look like when I see her back for neuropsych testing. But my guess is she's going to be a lot better.
I have a question. After I re-quit, I can't live without it, because my legs are worse than
Yeah.
myself.
That's the cost-benefit analysis, right? You have to think about sometimes. You have to tolerate some of those other side effects.
The same thing with antihistamines.
Exactly.
And that where we live, it's like.
The worst, yeah. No doubt, and that's the conversation that you have to have with your doctor about that. So, this is my dad with Parkinson's, all right? Before he passed away, that's one line. So, don't forget about the caregiver, right? I talked about it. This affected all of us in our family, yeah, not just him. And I know a lot of good care partners here, you know, who are, you know, wonderfully supportive and intimately involved in the process of the disease. So don't forget about the care partners and make sure that you treat those symptoms, you know, that you might be seeing as well, because stress can accelerate some of the cognitive and psychiatric changes we've already talked about. So this is who's in our lab at Frazier. It's me, Dr. Lennox, Dr. Midden. We're gonna hire our 4th one, we're growing. We used to have to wait 10 months to get in to see me for neuropsych, and now we're down to 4 months. So we're growing. We have a couple technicians too. That's my contact information. And I have cards if you need it, but otherwise, thank you so much for your time.
Thank you.